Happy Friday, everyone. Thanks for joining us for this month's CHETchat. We're going to give folks a few more minutes to stream in, and then we'll start with a brief introduction, and then we'll turn it over to Dr. Roque for what should be a really interesting conversation about the financial toxicity of gynecological cancers. So we'll be with you shortly. Happy Friday, everyone. Thanks for joining us for this September CHETchat. We're going to get started shortly in the interest of time and to make sure Dr. Roque has an opportunity to get through his entire presentation, and so we can have some time for questions at the end. We're super happy that you were able to spend your Friday lunch hour with us. I'm going to go ahead and jump into an introduction for Dr. Roque so that we can get started. So thank you for joining us for our CHETchat Spotlight Series in recognition of Gynecological Cancer Awareness Month. Today's discussion is an open conversation about the financial impact of being diagnosed with a gynecological cancer. A few things to note: you've been muted upon entering this meeting. We ask that you please leave your audio muted during the event. You will be able to submit your questions through the chat feature. We will answer those questions throughout the webinar. The Center for Health Equity Transformation's mission is to lift health for all, exposing root causes of health inequities and serving as a hub that pushes boundaries in research, education, workforce development, and community engagement. Our vision is to bridge the gaps between research, community needs, policy by transforming systems and structures so that everyone has the opportunity to achieve their best health. So today's CHETchat is titled The Financial Toxicity of Gynecological Cancers, featuring Dr. Dario Roque. It's my pleasure to introduce Dr. Roque, an assistant professor of gynecological oncology at Northwestern University, Feinberg School of Medicine. He has an extensive experience in the management of endometrial and ovarian cancer and offering his patients minimally invasive procedures. Currently, Dr. Roque strives to improve healthcare equity in the gynecological care while focusing on cancer disparities amongst minorities. He is an involved contributing researcher to the Northwestern University Cancer Health Equity Research Board, also known as NU Cheers, also known as the P20. As assistant professor, Dr. Roque strives to provide transparency, fairness, and continuously seeks implementing strategies to increase enrollment of minorities in clinical trials. So let's give a warm welcome to Dr. Roque. Also, we have a special treat for you today in that Dr. Nisha Mohindra was able to join the call, and she'll be helping to answer some of the questions towards the end of the presentation. So with that, happy to turn it over to you, Dr. Roque.
Thank you, Tanisha. So I'm gonna go ahead and share my screen. All right. Here we go. All right, so hopefully everybody can see the screen. So thank you again for having me and inviting me to do this talk, and I'm really excited to be here and just share some of this information with you guys. And I'm looking forward to our discussion at the end of the presentation. So just like starting with some basic definitions. So how do we define financial toxicity in medicine in general? But it's essentially what we would consider to be financial hardship and financial concerns that are experienced by patients and their caregivers because of a disease and its related treatment. So this is some of the framework that has been used within GYN oncology, and we'll talk a little bit more about the study that uses this framework later on. But for example, this is some of the causes of financial toxicity in general. So it could be the patients have been referred to collection because of inability to pay their bills. It could also just be an issue with utilization of financial assistance, whether they're receiving assistance for copay, assistance for covering drug costs, or even just having to have social workers involved as a way to help them with some of the financial concerns. There's also ways to define if the patient is experiencing financial toxicity using this instrument. It's essentially an 11-question survey that asks different questions of the patients, and based on the scores, those patients can be defined as experiencing financial toxicity. And then, so why does it matter? And it is something that is on patients' minds as well as on their caregivers. So this is the ASCO National Cancer Opinion Survey. This was from 2018, and essentially they provided survey almost every year. And back in 2018, there was about 4,800 responders. 20% of the responders have or had a cancer diagnosis. And if you see here, just as many Americans that were surveyed were worried about the financial impact of cancer, which was almost as much as the fear or the concern about dying from cancer. Now, these are not mutually exclusive. So it's not that patients were more afraid of not having the ability to pay for their care as afraid of dying of cancer, but that is quite a remarkable number. And just in general, this included also not only patients that had cancer, as I mentioned, only 20% of the patients of the surveyed members of the Americans that were surveyed had cancer, but even the caregivers expressed significant concern, and they describe ways in which they had to adjust their lifestyle and their financial well-being in order to pay for cancer care. So, and that included going into savings accounts. About 35% of caregivers had to do that. Many of them had to work extra hours. Many of them postponed retirement or took an additional job. And 43% of patients that had cancer that answered the survey basically said that they had trouble or barriers accessing care, or what they would think was the best possible care because of health insurance coverage. So this is something that is very much in patients and caregivers' minds. So this was a more recent national cancer survey, also conducted by ASCO. And basically, it demonstrates how financial concerns cause significant anxiety for patients that have cancer, but also for their caregivers. So if you see here, about 60% of patients that have had or had cancer were very anxious because of the financial concerns, and as many as 62% of the caregivers. So again, these are not even the patients that have cancer, but the patients, the caregivers that are providing care for these patients. And the affordability question, the majority of caregivers were very, very concerned about being able to afford the cancer treatment, more so than the patients themselves. And a lot of times this has to do with the fact that in many cases, it's because cancer tends to affect people that are older in general. A lot of times they're being financially supported by their caregivers or other family members. So when we think about this crisis of affordability for cancer patients, it's multifactorial, but some of the newer issues have had occur over the last few years that have led to this major issue is the increase in the use of oral drugs. So this is something that has happened over the last decade, as I'll show you in the next few slides. And in addition to that, the oral drugs that are being used, those prices have actually been increasing significantly year over year. There's also more increasing cost sharing. So what you would think of as out-of-pocket costs for patients themselves. And along the same lines, there's limited coverage for some of those oral drugs. So what this all means is that a lot of the cost, it falls on the patients and their caregivers. So this is how much the use of oral anti-cancer drugs have increased over the last decade, essentially. So this is the number of patients that have started one of 44 total oral targeted cancer drugs annually. And a lot of this has to do with the fact that more patients are using it, but there's also been a number of oral anti-cancer drugs that have entered the market. And I'll talk a little bit more specifically within the GYN oncology world in a few slides, but you can see that this has been sustained and incremental growth year over year, and has continued to be the case, and this has been true over the last decade. In addition to that, the cost of these drugs have actually been increasing, as you can see in this graph. And it's not only that the cost has been increasing, but the out-of-pocket costs for the patients have also increased over 15% during this time period, especially over the last decade. And the out-of-pocket expense, so the cost-sharing payments, unfortunately, have outpaced the wage growth. So patients and their caregivers are paying more or sharing the cost of these treatments more so than they did in the past. But the amount of money that they're making, so their wage growth has not kept up with this increasing cost. So all of this is just it's essentially not great because it's just like a formula for essentially financial disaster, as you might imagine. This is another way of looking at these out-of-pocket costs, and this was only looking at 2019. And what I wanted to highlight here, which again, I'm gonna go into a little bit more detail later on in the talk, so you can see how many of these drugs, the costs are truly astronomical. And the ones that are shown here with the red arrow, so these are drugs that we use fairly consistently in ovarian cancer. So that's one of the cancers that we discuss a little bit deeper later on. But as you can see here, some of these out-of-pocket costs are truly astronomical, in the order of over $10,000 consistently. So one of the questions we have is like, well, so how many patients are truly experiencing this? Is it like a minority of patients? Is it, like just a small percentage? And this was a study that was done out of Sloan Kettering, and this just encompassed 2 years from, actually about 3 years, so from 2016 all the way through 2018. And there were about 90,000 patients that were actively treated at Sloan Kettering. And 22,000 of those patients, so 25%, were noticed to have had experienced objective financial toxicity. And this was defined by some of the criteria listed here. So either patients that had more than 2 bills sent to collections, patients that had to go on a payment plan, had to do some sort of settlement, had to declare bankruptcy. So essentially a number of very objective measurements that would qualify these patients as having experienced financial toxicity. So that's a quarter of the patients that were being treated in a Sloan Kettering over a 3-year period. So what this graph is showing, the issue with financial toxicity is truly true regardless of the cancer type. So these are, you can read at the bottom all the different cancer types and essentially the level of financial toxicity. Hodgkin's lymphoma appears to have one of the higher rates of financial toxicity. But once we start looking at gynecological malignancies, and we'll primarily be discussing what we think of like the big 3 GYN cancers, so cervical cancer, ovarian cancer, and endometrial cancer. But as you can see here, cervical cancer is like in the top, 5. of the rate of patients that experience financial toxicity. And a lot of this has to do that cervical cancer is also a disease that tends to affect patients that have lower socioeconomic status. Ovarian cancer, somewhere kind of like in the middle. So about 30% of those patients also experience financial toxicity. And all the way here to the right, still it's uterine cancer, again, like about 25%. So consistent with some of that findings from that study from Sloan Kettering. So are there factors that are specific to GYN cancers that contribute to this financial toxicity? And absolutely, the answer is yes. But I thought one thing that we could do, just because, you know, I assume a lot of people in this that joined the talk are not very familiar with how we manage the different gynecological cancers. So I was going to very briefly review some of the treatment paradigms that we follow for each of these cancers and try to highlight some of the changes that have occurred over the last few years, including the approval of newer medications that in a way has truly impacted not only the way we treat these cancers, but the financial concerns that I was previously discussing. So starting with endometrial cancer, which is the most common type of gynecological cancer in the US. So this is a type of cancer that the majority of patients are going to undergo surgery. And in a way, most patients, that might be all they require. However, depending, and this is kind of like a very complex slide, so I don't want you to focus so much on the different molecular classes up here, but I mainly wanted to show this just so that you understand some of the complexity that goes into the decision-making for managing endometrial cancer. So many patients will go surgery, and a lot of times that's truly all they need. But then a decent number of patients will need adjuvant treatment, and that can be either in the form of radiation or chemotherapy, sometimes both treatment modalities. Then many of those patients will go into surveillance. And for those patients that recur, currently the standard of care in the second line is what they are commonly known as targeted therapy. So in this case, we use a medication called pembrolizumab or Keytruda. So Keytruda was approved by the FDA for the management of a subset of endometrial cancers. Again, this could be a talk, like a 1-hour lecture in and of itself, but without getting into much detail. So Keytruda itself is approved as a single agent for a subset of patients with endometrial cancer. And this was approved back in May of 2017. And then more recently in September of 2018, the combination of Keytruda with lenvatinib, which is an oral medication. Keytruda is administered IV, but this combination was also approved in September of 2019 for the treatment of another subset of endometrial cancer patients. More recently, dostarlimab was approved. So this was in April 2021. And again, this is approved as a single agent for a subset of patients that have what's called mismatch repair deficient endometrial cancer. So switching gears a little bit for ovarian cancer. So the majority of ovarian cancer patients, the initial treatment is a combination of surgery and chemotherapy. However, over the last couple of years, there's been these 3 trials listed here. So SOLO-1, PRIMA, and PAOLA-1, that because of those findings in those trials, the use of PARP inhibitors, and PARP inhibitors are drugs that have been approved probably over the last decade or so. And we have been consistently using them in the maintenance treatment of patients with ovarian cancers, specifically those that had a BRCA mutation. But based on findings from these studies, 2 of those PARP inhibitors have actually moved into the frontline setting. So the 2 that I was talking about, so it's Zejula or niraparib, and then Lynparza or olaparib. So these are oral medications that the patients can take at home, so they don't have to come in for an infusion. And they're both approved for the maintenance setting in patients that have ovarian cancer. In the case of Lynparza, it's predominantly patients that have either a BRCA mutation or if they have a homologous recombination deficiency, which again, you know, not to go into too much detail, but it's about 50% of patients that have ovarian cancer or high-grade serous epithelial ovarian cancer will qualify for treatment with maintenance olaparib, niraparib or Zejula. So that is approved regardless of molecular markers, also in the frontline maintenance setting. And these are approvals that have occurred over the last 2 years. Now, bear in mind that these medications have already been approved in other settings within endometrial, I apologize, for ovarian cancer. So we have been using them for several years now. And then there's also rucaparib or Rubraca, which is another PARP inhibitor. So these are all kind of like the same drug class. And this one is approved for maintenance treatment of select patients with recurrent disease. But these are, again, newer oral medications that have entered the market over the last decade. So what about cervical cancer? So for cervical cancer, there's been a couple of changes. One major change in the way that we manage early stage disease. So patients with early stage disease usually are undergoing surgery or radiation. But once patients have more advanced disease, surgery is really not part of the treatment. So you're looking at the combination of radiation with a small amount of what's called sensitizing chemotherapy versus radiation, and I apologize, versus chemotherapy for patients that have metastatic disease. So over the last few years, a couple of major changes have occurred. So one of them was the way that we do the surgery for those patients that are able to undergo curative surgery for cervical cancer. So for many years, we were doing the surgery minimally invasive, which allowed patients to recover a lot quicker, had lower risk for infection, shorter hospital stays, etc. However, this trial that was published that demonstrated that patients that were having minimally invasive surgery as opposed to having an open surgery, so like a more traditional type of operation, their oncological outcomes in terms of survival and recurrences were worse when patients were having minimally invasive surgery. So the way that translates into cost is like, because once patients are having open surgery, they need to spend more time in the hospital. There's higher risk for infections and some of the surgical comorbidities occurring. Looking specifically at the way that systemic treatment has changed. So again, Keytruda, which we talked earlier on when discussing endometrial cancer. So pembrolizumab or Keytruda is also approved for the management of patients with cervical cancer. And over the last few years, this was primarily approved in the recurrent setting, but based on more recent data, we have been using Keytruda more and more frequently for patients that have PD-L1 positive tumors in the frontline setting. And this is in combination with chemotherapy. And then as of in September 2021, there was a new drug that was approved. It's called Tivdak. It has a very long name, so it's tisotumab vedotin, so we can refer to it as TV or Tivdak for short. But this was approved in September of 2021. And again, just to illustrate how much the field has changed over the last few years. And just for reference, so these are kind of like estimates, but they're pretty close to reality. So these are some of the costs of some of these drugs. So if you're looking at pembrolizumab, so again, Keytruda, that we use very consistently in treating patients with endometrial cancer and cervical cancer, so it's about $10,000 per infusion. So the infusions are usually every 30 days. So if you do the math, someone's on it for a full year, that's about 17 treatments. Lenvatinib, which again, this one is used for endometrial cancer, is about $24,000 a month. So this is a pill, which again, patients can take at home. Olaparib and niraparib, so these are those two oral treatments that are used for ovarian cancer. So they're about $16,000 a month. And then tisotumab vedotin or TV, so this was the drug that was approved for cervical cancer. So you're looking at about $6,000 a month. So what does that mean for patients? I mean, obviously, patients cannot afford, or most patients will not be able to afford the market cost of those medications. So for patients that have insurance, depending on the type of insurance that they have, their out-of-pocket expense can be quite significant. So this was a study that just looking at the use of PARP inhibitors and out-of-pocket expense. So kind of like the first two rows, so these are looking at patients that have regular health plans, so non-Medicare, non-Medicaid. So the patients that had a high deductible health plan, for the most part, they were not having any out-of-pocket expenses. Once you get into like not a high deductible, it's about $45 a month, which, you know, arguably affordable. Patients that had Medicare but also have Medicaid eligibility, also their expenses, it was actually most of the drugs were covered, which is good because again, these are the patients that are the lower socioeconomic status and the patients that need the most assistance in terms of medical coverage. Now, once you start to get into the Medicare, so these are patients that are, qualified for Medicare, so that means they're elderly on a fixed income. So unfortunately, these are some of the patients that are paying the higher out-of-pocket costs. And if you look at those patients that did not have dual Medicaid coverage, you're looking at about $900 a month for out-of-pocket expenses. Once you get, and this is all for Medicare Part D, which is prescription drug coverage, by the way. Once you get into what's called the catastrophic phase, so if you're not familiar with kind of like the way Medicare Part D works, there's this portion of it that essentially the patients pay a small nominal out-of-pocket. They have to meet a deductible, and then beyond the deductible, some of the drug costs are covered, but it's up to a set amount, which I believe is about $7,000 annually on average. So once you meet that $7,000 annually, then you go into this catastrophic phase where you have to pay 5% of the cost of the medication. So some of these patients, if they were on a PARP inhibitor, were paying about $1,000 a month. So that's $12,000 a year, which is not an insignificant amount. Now, looking at pembrolizumab in terms of the cost sharing, and this is straight out of the Merck website, which is the manufacturer for pembrolizumab. So this is for Medicare patients that are on Medicare. About 80% of them had to pay between $1,300 to $2,100 per infusion. So again, if these patients are on pembrolizumab for about a year, that's like 17 infusions. So if you do the math, it's about $22,000 to $36,000 for 1 year of treatment. Now, these patients are not necessarily paying all of this because there's some other coverage that they can obtain, but that is a lot of out-of-pocket expenses that are not being covered by Medicare. For patients that have commercial insurance, as I showed you on the previous table, those patients have a little better coverage, but still some of them are paying up to $300 per infusion, which if you do the math and multiply by about 17 infusions a year, that comes to about $5,000 for 1 year of treatment. And many of these patients, not all of them, because certainly if they recur early, then we will stop the treatment. But for some of these patients, the treatment itself is for up to 2 years. So you can run into significant costs if you're having a good response to the treatment, which is a good thing from the cancer perspective, but not so great from the financial perspective. So just so that you have a sense, so this is now looking at Medicare Part B. So this is coverage that usually covers medications that are administered in the inpatient or like an outpatient, but it's something that is being administered by a provider. So essentially all the IV or intravenous chemotherapy that we administer. So these here are like the top 10 selling drugs that are covered by Medicare Part B. And if you look here, guess what? So 4 of these drugs, the ones that are highlighting in yellow, are cancer drugs. One of them, so this one, bone marrow stimulant, so it's not technically a cancer drug, but guess what? We do use them very frequently because a lot of times patients that need bone marrow stimulations are those patients that are needing chemo. So I did want to highlight it here because many of our patients also incur that cost. So if you look here in the top 10, there are 3 drugs. When you look at Keytruda or pembrolizumab, Neulasta, and Avastin that we consistently use in patients that have gynecological cancers. And then on the shot on the right, what it's showing is the out-of-pocket cost. So this is like a more realistic out-of-pocket cost on a yearly basis that a lot of our patients are incurring. So again, for Keytruda, you're looking at about $9,000. For Neulasta, it's about almost $3,000. And then Avastin or bevacizumab, it's a little less, about $1,000. But just to give you an idea, so currently when we treat patients with cervical cancer, if they meet criteria, we're actually using Keytruda plus Avastin plus 2 other medications. So those patients, you're looking at about over $10,000 of out-of-pocket costs. And then that's not accounting for some of the other treatment-related factors that impact the patient's finance. So if you look at time out of work, for the most common type of chemotherapy that we administer, so it's a combination of carboplatin and paclitaxel that essentially the majority of our patients with GYN cancers will receive as a frontline treatment. That treatment is every 21 days, and the infusion itself is about 5 to 6 hours. So that is it's like a full day that the patients have to spend in clinic. So that could be quite impactful if they're employed. Not to mention some of the side effects and the fact that they might need to take additional time off work to recover from the chemo itself. If you look at when we use radiation, so this is as frequently as daily treatment for 5 weeks. Which again can be very inconvenient and can result in patients not being able to maintain their jobs. The treatment itself doesn't last long, but as you can imagine, this can be very disruptive, especially if you're traveling long distances to come to the hospital to receive the treatment. There's also the time of work for the caregiver. A lot of our patients need someone to come with them to their appointments, to ask questions, or even to drag them. So the caregiver herself might not be able to, might need to take time off work. Then you look at some of the travel expenses. So there's gas, there's parking, et cetera. And this is just, scratching the surface. But there's also the issues of home care and caregiving. So there's a lot of other financial factors that go into the impact that a cancer diagnosis can have for patients. So looking specifically, so taking all of that into consideration, there's some smaller studies that have looked specifically at some of the factors and patient characteristics that increase the risk for patients having financial toxicity. So this was a study where they used a cost survey that I described earlier, and it included 240 patients. So all of these patients were treated at one hospital in Boston. All of these patients had insurance because at the time when the survey was conducted, Mass Health had already been established. So this is a health plan that precedes the Affordable Care Act. It is state sponsored. So all of the patients in the study had insurance, but 45% of them had some sort of government or state, or either federally or state sponsored plan through Medicaid, Medicare, or Mass Health. Notably on this study, 86% of the patients were white. So the reason I bring that up is because it's not a good representation for the US population in general, and certainly not a good representation of many of the patients that we take care of. When they look at after the patients responded to the survey, they looked at some of the factors that were associated with financial toxicity based on the survey score. And some of these factors included Black, Hispanic, or ethnicity or race. That so essentially, Black or Hispanic patients were an increased risk for experiencing financial toxicity. If they weren't some sort of government-sponsored insurance that did not have a supplemental coverage, annual income less than $100,000, if the patients were unemployed, cervical cancer, notably, so it more so than the other types of cancer. And again, in a way, not surprising, because we do know that many of the patients that experience cervical cancer tend to be of lower socioeconomic statuses, and if the treatment included chemotherapy itself. So these were all like single variables that the investigators identified as having increased risk for patients experiencing financial toxicity. Now, they did what's called multivariate analysis. So for those of you in the audience that might not necessarily be familiar with statistics, this is where they look at more than one variable at once to try to truly identify the variables that are driving some of the results. And what they noticed that there were only 3 variables of all the ones that I previously mentioned that truly contributed to the financial toxicity. So, and those were whether the patients had government insurance without supplement, income less than $100,000, and if chemotherapy was part of the initial treatment. Now, notably, as you see here, like the Black or Hispanic race and ethnicity dropped out of in this multivariate analysis, but bear in mind that this was, in terms of the patients they included, it was a very, very small sample size. So only 14% of the patients in this study were non-white. So not truly representative of the general patient population in the US. One thing that they identified, and again, this goes along with what we were discussing earlier, but how much financial toxicity can impact what patients do in order to overcome the financial toxicity. So 22% of the patients delayed or avoided care. So that was 7 times more likely than patients that were not experiencing financial toxicity. Almost 30% of patients had to borrow money. 50% of patients had to use savings to meet the cost of care. 30% had to reduce spending on the necessities. And up to 40%, 43% of patients had to reduce spending on leisure activities. So just to demonstrate how much financial toxicity can have a significant impact, not only on the care itself, but just on regular daily activities. So this was another study. So this was done a little bit differently. So this they define financial toxicity based on these factors listed here. So this was conducted out of Memorial Sloan Kettering. They included over 4,600 patients, and they surveyed, they obtained the data retrospectively over a 3-year period. And this was done by Dr. Aviki and her colleagues. Dr. Aviki is truly, she's a leader in the area of financial toxicity in GYN oncology. So this was a great study. They, similar to the other larger survey that have been done in Sloan Kettering, they identified 25% of patients when looking at that criteria. So about 1,100, almost 1,200 women that experienced financial toxicity. And these were some of the risk factors that they identified as acting on their own. So women that were younger, again, Black or Hispanic, race and ethnicity. Notably, this study was much more heterogeneous. It was Sloan Kettering, as you know, it's in New York City. So a very diverse patient population that they see. Self-paid insurance status, certainly that you can imagine that can significantly contribute to financial toxicity just from the fact that a lot of these patients are incurring out-of-pocket expenses. If the patient was non-partner, in terms of disease-specific factors, again, cervical cancer was the one type of cancer that was the most associated with financial toxicity. Higher stage of disease, and this has to do more with the fact that often as the higher the stage, the more treatment modalities the patient may be exposed to, especially systemic treatment with chemotherapy. Some of the healthcare utilization factors, so if patients were enrolled in a clinical trial, that also incur financial toxicity, and this has to do largely or probably due to the fact that many patients in clinical trial have to do multiple visits to the site for lab work, etc. Inpatient stays, so the more the patients have to be admitted, the more the financial toxicity. Same thing with the more number of outpatient clinic visits, the higher the financial toxicity. Treatment type, so certainly chemotherapy, those that can drive up the cost significantly, and number of imaging studies, so CT scans, etc. So they also did, this multivariate analysis just to try to identify the factors that were driving the most financial toxicity, and these were the 5 factors that they identified. So non-partner marital status, Black or Hispanic race, insurance type, so if their patients were self-paid, the number of imaging studies, and the number of outpatient clinic visits. Notably, they noticed that patients that were older and had Medicaid or Medicare insurance were somewhat protective against financial toxicity. And it's kind of hard to get a good explanation. And I think certainly having any sort of insurance coverage is going to help tremendously. Certainly with Medicaid coverage, even though those patients are likely to have lower income, more of the medical expenses might be covered, which might protect against financial toxicity. But this goes to the idea that often government assistance can help protect these patients from financial ruin. So this is just some of the ways, which this is another study that Dr. Aviki did, looking at how financial toxicity itself can impact the significant burden that it can have on the patient and their family. So it can, as we discussed from the other study, reduce spending on leisure activities. Some patients are skipping rent payments. Some patients have to remortgage their home. So a number of measures that the patients had to take that are truly significant, not only for themselves, but for their family members. One of the major ones that we see is medication non-adherence. So up to 27% of patients were identified in this study. So this included 22% of patients who did not fill their prescription because it was cost prohibitive. 14% of patients who either skip the doses or make the meds last longer. 5% who totally skipped, took less, or didn't fill their chemotherapy prescription. So this 5%, that's actually cancer patients. This is looking at, so, what is the risk of bankruptcy just from the financial toxicity that comes from healthcare. So this was almost 200,000 patients, and out of those, 4,400 had declared bankruptcy. So that's like 2.5 times the risk of bankruptcy with a cancer diagnosis. And then it's not only affecting their personal lives and their family, but it actually leads to worse cancer outcomes. So this was a study that included 7,500 patients, and they had found that like bankruptcy after a cancer diagnosis was associated with 79% increased mortality risk compared with the patients that were not experiencing bankruptcy. So are there any solutions? And recently, I mean, if I had given this talk a little over a month ago, I probably would not have been able to include this slide, but this is like a major change at the healthcare policy level, which is often where the biggest benefit can come from. So the implementation of the Inflation Reduction Act. So this was, for those of you who were not aware, so this was signed into law by President Biden in August 16th of 2022, so a little over a month ago. And these are some of the changes that are within that bill that are actually aimed at reducing drug costs. In terms of what we're talking about from the perspective of savings from the patient's perspective, so it's essentially starting with in 2024, it's going to eliminate 5% co-insurance for Part B once patients get to that catastrophic coverage. So that's going to be significantly cost saving for patients. In addition to that, by 2025, it's going to add a $2,000 out-of-pocket cap in Part D. So essentially, patients will not have to pay more than $2,000 a year. So remember, currently patients are spending $2,000 for some of these medications in a two-month period. And then starting in 2026, there's going to be negotiated prices between Medicare and the pharmaceutical companies. So the first year, they're going to be 10 drugs, all within the Part D. So essentially, Part D are drugs that are given as an outpatient. There's going to be another 15 Medicare Part D drugs in 2027. Starting in 2028, some Part B medications. So this is where medications such as pembrolizumab, Keytruda that we were talking about. So those are also going to be, the price will be negotiated, and then 20 more in 2029. So by 2030, about 60 total medications, there will be price negotiations. And as you remember, so the top 10 of the medications that are the ones that are more that cost them more in terms of Medicare, 4 of those were in the currency category. So I expect that this is something that would significantly benefit patients and can lead to lower financial toxicity. So what are other measures that can be taken on a more local level? So I think engaging and empowering the healthcare team. This is a survey also by Dr. Roque, where they looked at, whether or not providers wanted to integrate value and cost into their day-to-day care. And the majority of providers felt that they should be involved in this effort. The problem is that many of them just are not equipped to do so. So most of us have not been trained in, affordability of care, or how to have conversations with patients to address the toxicity, or even, to know what is it that is contributing to financial toxicity. So based on this data, Dr. Roque and her team, so this is a framework that they're implementing as Long Kettering, where essentially everybody will be a stakeholder, including not only the attending, but the fellows, the nurses, advanced practitioners, just to be better aware of it, or be better able to identify patients that may have a financial need, and ensuring that they're actually referred to like a financial counselors, or that they can reach out to the patient and see if there are ways that can help to help them with the cost of care. So this is based on that. This is a pilot program that they're implementing at MSK. So essentially, it's a universal financial toxicity screening and referral program. They're piloting it primarily in 4 services: in GYN, breast, colorectal, and lung. But some of the early data, they essentially they identified approximately 150 weekly referrals, which suggests that there's strong evidence for a need for these kinds of programs to better identify patients that are in a lot of need for help and support as they receive their cancer treatment. There are also some, simple practical solutions that could potentially improve affordability. So when surveying patients, 27% of them said access to free food during or around appointments or chemo infusions, having help with MetroCards or free rides to and from the appointments, minimizing wait time. So that's time that they can not necessarily be away from work. I mean, if there's an appointment, it's at 8 a.m. and patients are not being seen until 9:30. That's an hour and a half longer that patients may need to be away from work. So that's something that that could potentially be addressed. And then parking is a huge expense. So 1 out of 3 of NCI designated cancer centers charge patients on radiation for daily parking. And if you remember what I was talking earlier, so for some of our patients undergoing radiation, that's 5 days a week for 5 weeks. So if you do the math, that can be very, very costly for many of these patients. And then I think this is a good plug to also, for those of you that are patient advocates or have family members or that may have had cancer diagnosis, or you work in the community, prevention and early detection. This is another reason why it's so important, because pretty much for all 3 of our cancers, if detected early, a lot of times those are cancers that can be treated with just surgery or smaller procedures and don't require chemotherapy or radiation, which is where a lot of the cost is coming from. So for example, for uterine cancer, just increasing awareness about abnormal vaginal bleeding, postmenopausal bleeding, how it is never normal. The majority of patients, not all of them, but the majority of patients that we see that have more advanced uterine cancer is because they delay presentation or the diagnosis was delayed. So this is where patients being aware of their symptoms and advocating for themselves can be quite helpful, because it can really make a big difference. And if we're able to catch endometrial cancer early, which luckily we do most of the time, it's something that can potentially be cured with just surgery. Not to say that surgery is not costly, but if patients are able to avoid radiation and chemotherapy and some of the other treatments that are used for uterine cancer, that will make a big difference in terms of their financial well-being. Same thing with cervical cancer. We have excellent detection method. We have an excellent prevention method in the vaccine and the pap smear. So advocating for the use of both these interventions. If we're able to offer this and patients are able to do both of these interventions, again, we can detect cancer early and potentially prevent it altogether. The cost of patients with cervical cancer, it comes a lot of it from the surgery stuff, but certainly when more advanced disease is present, now you're looking at radiation, potentially chemotherapy. So that's where a lot of the financial toxicity is coming from. And then ovarian cancer, unfortunately, we don't have any good screening mechanism for it. So it is a lot more difficult to detect early. However, we do know that some patients that are increased risk of developing ovarian cancer. So any patients that you know or you treat or interact with that have a history of ovarian cancer or breast cancer, encouraging those patients and their families to undergo genetic testing. Patients that have a BRCA or BRCA mutation, if we're able to identify those patients early and their family members, when the women reach a certain age where we recommend risk-reducing surgery, we could potentially offer a risk-reducing removal of the ovaries and fallopian tubes and actually significantly decrease to almost eliminate the risk of them developing ovarian cancer, because the majority of ovarian cancer patients, when they present, they already have very advanced disease. So the majority of them will need to go on some sort of systemic treatment. So in conclusion, so financial toxicity is very common among patients with GYN cancers and can contribute to worse oncologic outcomes. The root of the problem is it's really multifactorial, so there's not an easy solution, but it is strongly driven by the high price of targeted therapies, especially over the last decade. And simple interventions may help alleviate the problem, but certainly multi-level reforms and policies such as the Inflation Reduction Act are truly essential, and we should continue to advocate for those. So with that, thank you so much for joining us, and then we're happy to answer questions, and I'm so glad that Dr. Mohindra is here as well. So let me stop sharing my screen.
Thanks, Dr. Roque. That was a very well-rounded presentation, so well-rounded and so thoughtful that you answered quite a few of my questions. But since you ended, towards the tail end of your presentation, you started to talk a lot about potential solutions, and one of them being in the Inflation Act that was just recently signed into law, and then also a lot of the research that's going on in more as Sloan Kettering. I wanted to know if there were any other solutions that you were thinking could really help in terms of addressing financial toxicity.
Yeah, I mean, and I'd love to hear Dr. Mohindra's thoughts on this as well, because she's done a lot of work on this area, just for not necessarily in GYN, but I do think, as I mentioned, I think prevention could be a huge way to address it, because it's the idea of helping patients not have to get to the point where you're requiring some of these costly, costlier interventions such as chemotherapy, targeted therapy, especially for endometrial and cervical cancer. These are truly cancers that if we're able to diagnose them early, we can cure them. And many of the times those patients don't recur. So that's one thing. So certainly just awareness about prevention and screening strategies. I do think that a lot of the interventions, just like they're doing at Sloan Kettering, may need to be at a local level, and trying to figure out how we can partner with within our cancer center and be better able to identify some of the patients that are having issues with just access to care or like financial issues, and see how we can help them. It's either through transportation, perhaps smaller interventions, so that patients that are having radiation maybe only have to pay for like a nominal parking fee for like the whole treatment. So I think there's many ways in which we can try to address this.
Yeah, I think this is where the field has struggled. It's so multifactorial. And I'll say this, that, I'm a lung cancer doctor, and we have a lot of new drugs, and now we're putting these really new expensive drugs into the curative setting, and we're doing it for up to 3 years of treatment on these oral, very expensive drugs. And I think what is hard is what can we do on many fronts to address this? And certainly drug costs is like one of the biggest ones, but even as people go into survivorship, they're foregoing good care because they've already lost a lot of time during their treatments, and they're foregoing all the care that we know could be very important to keep the cancer in remission. So we have, I think, at the institution looked at, screening with the cost survey and then getting financial counseling. I think the questions become capacity. Do we have enough of those people to financial counselors? And then secondly, I think the providers have all been very interested, but they say, we don't know what to do. We don't know how to counsel our patients. So at least asking has been one of the ways that we can start to address that and get people identified. We did a small study in minority, Asians and Indians, and some of these topics end up feeling taboo in different cultures, and they don't want to bring it up to their providers, or they don't want to bring it up to their healthcare team. So I think this is going to be an ongoing conversation of how do we address lots of different issues and lots of different cultural backgrounds around finances.
Thank you, Dr. Mohindra. Do we have any questions from the audience? I think that you all both made some good points about like what the real capacity is at the institutional level. I wonder if you guys have any thoughts or insights on how we could maybe better partner with some of our community-based organizations who are really have grassroots connections within the community. And I feel like there's an opportunity there, but I feel like sometimes that's underutilized or under leveraged. So I wonder if you guys have any thoughts or insights on how we could maybe bridge the gap between institution and CBOs to help address this issue.
Yeah, so I think one of the things that Dr. Mahindra brought up is the idea of, you know, the capacity for us to refer every patient that we identified to, let's say, you know, like a financial advisor in the hospital or even a social worker. Just if you think about most of these studies are suggesting 25% of patients are experiencing financial toxicity. So this is one way in which potentially partnering with either local health centers or community partners that help patients during their cancer care, and see how we can, in partnering with them, we can better help our patients navigate the different resources that might be available to them that a lot of times they're not aware of, because they, you know, our social workers know a lot of the resources, but if our patients are not meeting with them, I often don't even know. I mean, I know of a few resources, but I think this is where community partnering and working with health centers may be helpful, just engaging those social workers and financial advisors.
Yeah, there was a group somewhere, and I'm forgetting where it was, where it was a group of people who were either in the financial counseling space, and there were an organization outside of a hospital that could be a resource. So you could tell your patients, hey, you know, this group of people are willing to help. Now, again, I don't know what their capacity is, but I do think that there is probably room for a lot of collaboration. You know, if we don't have it in the hospital, where else can we get some of these resources outside? And I think it is a ripe place to look.
Thank you, Dr. Mohindra and Dr. Roque. I just want to highlight one of the comments from one of our attendees that says that triage cancer has one-to-one financial navigation for patients. So we'll do some investigating and see. I think you guys, thank you, Dr. Roque. Thank you, Dr. Mohindra, for your insights. I think you got us to really start thinking really critically about how we can really provide more services to our patients to make sure that they're not left on the edge of financial ruin after receiving high quality care in order to like save their life and have an awesome quality of life after cancer. So thank you everyone for joining us on a Friday afternoon for lunch, for a lunch and learn. We look forward to seeing you again at the next CHETchat. And with that, we're going to let you go back to your day. Thank you, Dr. Roque and Mohindra.
Thank you.
Fabulous talk.
Thanks.